Good morning. It's my pleasure to introduce today's speaker. Dr. Hayward is a practicing internist and geriatrician who has worked at Kaiser Permanente. Previously worked as the National Clinical Lead in Elder Care Management at Kaiser Permanente, and currently is practicing as a geriatrician. And today he's going to be talking to us about polypharmacy and deprescribing in older adults.
Okay, thank you, Liz. Yes, my name is Arthur Hayward. I worked at Kaiser for most of my career, so that's my only disclosure. I have none other. Thanks for coming this morning. I'm glad to see you. My job today, over the course of the next 45 minutes, is going to have to do with talking about polypharmacy and deprescribing, of course. I hope that by the end of the hour you're a little bit uncomfortable or a little bit uneasy about the state of affairs with regard to overprescribing that I perceive is rampant in the United States. So that's my bias. By the end of the hour, I hope you'll be like this physician here, who is not merely handing out the medicine or writing a prescription, but talking to the patient about the prescription and the side effects and the alternatives to prescribing a medicine. So the session objectives, identify examples of polypharmacy. That's not difficult to do, as it's all around us, as I intend to point out. Because I'm a geriatrician, I want to particularly recognize the risks and the altered risk-benefit ratio for elderly individuals. And then I want to say, in order to reassure you, there are deprescribing algorithms, so that if you're wondering how to do that in a systematic way so that it's safe, that provides some reassurance that it has been done, it's been field tested, it's been written about in the literature, and there are places you can go to find out how to do that safely. So this is not an M&M conference. It is more about deprescribing and polypharmacy, but I want to just mention a couple of cases from the annals of my personal practice. And I'll ask you just to keep these in mind as we discuss the issues over the next 45 minutes or so. The first case, a 45-year-old man who saw me for chronic pancreatitis, referred by a gastroenterologist, was on chronic opiate therapy for his chronic pancreatitis pain. Everything was going okay until one day he came in with his parents, and they all looked stricken. He announced that his wife had not waked up, had died during the night. Second case, an 80-year-old math teacher had dementia. His wife eventually had to have him put in a nursing home. She called me up and was very concerned because her husband, who was a formerly bright math teacher, had become a zombie, in her words. 74-year-old diabetic who was in the emergency room after a series of falls, had a hemoglobin A1C of 6%. Finally, a wife who said there was a daily struggle to get her elderly husband to take the medicines that he'd been prescribed by me. And so every day there was a kind of a contest to see if she could get the pills to go down his esophagus. I'll read the quote. "Man has an inborn craving for medicine. Heroic dosing for several generations has given his tissues a thirst for drugs. The desire to take medicine is the one feature which distinguishes man, the animal, from his fellow creatures." Oh, I didn't announce there would be a pop quiz. Are you ready? Who is the man who's pictured here in the upper left? Okay, William Osler. And there is also an award for a correct answer. Congratulations, Nick. There's your award. I'm going to suggest you use that coupon to, perhaps you can share a latte with a pharmacist and talk over the contents of this, if not today, soon at your convenience, okay? So you're right, it's William Osler, of course. And this was more than 100 years ago. Well, it was almost more than 100 years ago, and because he died in 1919. So was he prescient? He had no idea what was about to develop across the world with respect to miracle drugs. But if people were to look at that quote today, they might edit it a bit as some have, and talk more about the physician's role or the prescriber's role in the proliferation of polypharmacy. And when you read the newspapers now, you will read about promiscuous prescribing, and I hope none of us fall into that category, but I have to say I have maybe done my share in my career. So this is a kind of a cartoonish history of polypharmacy in my own mind. When patients look at pharmacists, what do they see? This looks like it's half animated, isn't it? It almost looks that way. But this is a pharmacist. What people see sometimes is just a bottle of pills, because that's what they're after. And I'm afraid sometimes when they look at a physician, they also see the prescriber who can provide them with that bottle of pills. So we know that drugs do perform miracles, and I would say the modern era of polypharmacy probably began with antibiotics in the 1940s or so. And some of the first uses of antibiotics, by the way, were in Portland when penicillin was made available on a early basis, not for military use, but for a daughter of a shipyard worker who had osteomyelitis with Staph aureus, and it was sensitive then to penicillin. So that was one of the first cases of penicillin being used west of the Mississippi. So as drugs became available, and as the miracles were duly noted, drugs became more and more widely prescribed. I'll give evidence if you don't feel that's been amply demonstrated in your own practice. And inevitably, I think drugs have become too widely prescribed, and this follows a kind of a technology curve or a cycle that's sometimes called the Gartner cycle, where new technology is adopted and proves its use, and it's fascinating to see how well it works, and so the usage rises and rises and rises until a point where people are becoming a little disenchanted because they understand there are not only benefits but also harms or misuses of new technology, and then they fall into kind of a slew of disillusionment, and I'm going to say maybe we are kind of at the crest of that slew of disillusionment with respect to polypharmacy. And that's when harms are result, and harms are more frequently identified. When that happens, in the case of polypharmacy, the solution that I'm proposing is deprescribing, and we'll talk about that. So outline features and problems, signs and symptoms of polypharmacy, especially with reference to the increased risk and diminished benefits in many cases in older adults. The solution I propose is deprescribing. What's happening outside and inside of Kaiser Permanente, I'll probably say more about what's happened in what I would call kind of a climate change with regard to the perceptions of polypharmacy and drug usage, and then finish up with what I hope everyone will agree are the benefits of deprescribing. So this is sort of my outline, and I want to just start. I see people in the back, and I'm just going to say, wait, is this the time to welcome you to come on down? Because there are plenty of seats here. And tell me, raise your hand if I'm not audible if you have questions, because I don't mind being interrupted. So what is reflex prescribing? I would say in the days of a prescription pad, it was the quick draw. It was almost a muscle memory, pulling out the prescription pad and putting the pen to paper as soon as you heard what the symptom was, because you quickly and efficiently thought, oh, that's the symptom, that's the condition, I have the solution, and that's from like A to B and done. I think the reflex today would be the fingers over the keyboard, because it maybe in many cases is easier to hit a few keystrokes and prescribe a medicine. Another kind of reflex prescribing would be, I think, the misapplication of guidelines, and that's especially pertinent for elderly individuals when much of the evidence for the use of medicines according to guidelines has been generated by studies and clinical reviews for patients who are younger, and then those results are applied to elder individuals who have different considerations and risks and profiles of conditions. I have to say, it's not deprescribing, it's just not prescribing. If you have an option to not start a drug, then maybe there is a better solution, and that's something that I would encourage everyone to think about. Talk more about that in a minute. So as an example, and this might be, the evidence here might be a little bit murky, maybe you don't agree, but I'll go here so I can On this slide, I'm going to show you that this, by the way, is a study from Oregon State University, and it's based on a nationally representative database, huge nationally representative database, and they're looking at statin prescriptions, and they look over the years 1999 to, I was afraid of that. They're looking for 1999 all the way out to year 2009, maybe it crested there. But this is statin prescription for older adults. In this case, older adults are those 79 years or older. And you see that even for primary prevention, in other words, people who have not had a heart attack or stroke, who don't have peripheral vascular disease, there's still about 30% who are being prescribed statins. And that's really not subject to guideline. That would be an example, I think, of extending a guideline to individuals who are older than 79 when the evidence is based on younger people, and in most cases it's based on people who have risk factors or for secondary prevention.
What do you think? Do you think we should prescribe or not?
I was afraid of showing that example. I created that example, and then, as you know, there's been more evidence about use of statins in the meantime. That's why I have to concede the evidence may be a little bit murky. So to answer that question, I don't have a simple one-line answer. I have to say, you need to look at the evidence, and where did the evidence come from? Was it in 79-year-olds who did not have risk factors, did not have a history of coronary heart disease? No, it wasn't. It was in younger individuals. So the data has been extrapolated to older individuals. Do they have the same time course for achieving and accruing the benefits? Those are the considerations. And then the out, of course, is shared decision making. So if you know the answer to the question you just asked, Joe Selby at the Patient-Centered Outcomes Research Institute in Washington would like to talk to you. Because we don't have an official formal answer. But I'm suggesting that it does need to be, we pause and stop for a minute and think, do 30% of adults with no history of heart disease, peripheral vascular disease, or stroke need to be on statins? And I'll leave that question with you, okay? Here's another example of reflex prescribing, which results in the drug cascade. The cartoon, I will read, if the drugs do cause a problem, then we've got some pills that might help, and some other pills for the side effects of the pills you take for the problems that drugs cause. So we get into kind of a cycle of prescribing, and I'm here going to give a ridiculous example of prescribing that none of us would fall prey to, starting at the top with a patient who has hip pain. And in my practice, I often picture the patient who's in the nursing home, and you get a telephone call and you're busy in the office, and you say, hip pain, elderly patient, osteoarthritis, let's try ibuprofen. So that's prescribed. The next call that you get or somebody else might get is to say, now we're recording that this patient has hypertension, and instead of thinking, oh, that might be related to fluid retention from the ibuprofen, you think, oh, hypertension, well, hydrochlorothiazide is good for that, so that's prescribed. With the hydrochlorothiazide, you get an increased amount of urine flow, maybe urinary frequency, and in an elderly individual, you think, okay, don't we have an antispasmodic that's good for that and treats the bladder? So that would be oxybutynin, and that leads, in many cases, or in a sufficient number of cases, to urinary retention. Urinary retention, is it a male? Well, it may very well be a male, even if it's a female. You think, okay, we have an alpha blocker, that's terazosin, so let's try that and see if we can cut down on the urinary frequency. And then you go to see the next call is about orthostasis, because the alpha blocker is often associated with orthostasis had a side effect. Now, you may not, this may be different prescribers as you proceed around this ring. It may even be you if you're busy and you want to do this kind of reflex prescribing. But the orthostasis puts the patient at risk for a fall. And the fall then results in the hip fracture. We're back to the start, but now we have a condition that's much more serious, and it leads to increased mortality. So that's intended to be a comical example of something that we would never do. I want to move on now to kind of a sidebar discussion about narcotics, because that's what That's what people are calling now the real drug problem in the United States, and that is a wide prescription of narcotic analgesics. So that's been labeled a narcotic epidemic. How did we get there is a question that is worth considering. A different sidebar. Well, this may be another pop quiz. I think this is a pop quiz. If we're looking at this amount of money that's spent by drug companies in payments to physicians every year, and it comes usually in the form of meals where there's a promotional, educational component. What's the amount of money the drug companies spend on these, say, payments to physicians per year? Is it 20 million, 40 million, 80 million, 100 million? 500 million. Have you been reading? Anybody else? I'm afraid it's 225 million. Okay. Oh, something happened there. The 225 million didn't come up on the screen, but that would be the correct answer. I'm sorry. I'll give you another chance in a bit. But 225 million is still a significant amount of money, and what does that buy? Again, I'm off on a little bit of a tangent here, but I'm just going to say this study kind of attracted my interest because there are now databases available that show what prescribing patterns are for every physician who writes a prescription for Medicare patients. And you can look at that database and see what the pattern is. There are also now, under the Accountable Care Act, is an obligation for pharmaceutical firms to report who gets any funds they spend for meals. So any physician who goes to one of these educational luncheons or dinners is recorded in that database. And what has turned out to be the case is that if you have no meals, this would be your prescribing for that particular class of medicines. And with each meal, starting with the first meal, you are prescribing a higher proportion in that drug class every step of the way. 1 meal, 2 meals, 3 meals, and 4 or greater meals, you prescribe more of the medicine that's being promoted by the pharmaceutical firm. So they feel like they're getting some of their money's worth out of promoting these drugs. These are newer drugs. They're drugs that maybe you haven't heard of. This class would be statins. This would be the cardioselective beta blockers. These are ACEs and ARBs. This is the SSNRI group of drugs. So the drug companies clearly spend money, and they are able to promote their more expensive and typically newer medicines and get them into the marketplace and increase their market share. So that's what I call kind of a form of pharmaceutical hype that anybody go to? No, not in this crowd. No. Anybody go to these drug company sponsored meetings? You do it for market intelligence maybe? You want to just see how drugs are being marketed? But there is an insidious influence on prescribing patterns. Now these three curves are rates of opioid overdose death, sales, and treatment, and it's not surprising that they're fairly parallel, and the chart here runs from 1999 out to 2010, and you will see that Americans consume 99% of the world's hydrocodone, but only 80% of the world's supply of prescription opioids. So that's sounds like it's more than our share, doesn't it? We all know this, so I won't belabor it, but we have gotten to the point where there are more deaths from opioids and drugs, substance abuse drugs, than there are in traffic accidents. I'm going to say, if I see people in the back, I'm thinking, oh, would you like to have a seat? Because this intermission, come on down if you'd like. Can you hear me? Yeah, okay, you're content back there standing. Okay. Quick exit if need be. So this is a good thing. I guess the traffic accidents maybe have tapered off in the United States, but they've now been overtaken by narcotics, and this is overdoses not only from intentional purposes, but also accidental overdoses. So it is as Thomas Friedman says at the CDC, it's an epidemic of narcotic overutilization. And the CDC has become concerned enough that they have put out guidelines, and this is some of the content that they cite. Since year 2000, both opioid prescribing and deaths from prescription drug overdose have quadrupled. The use of opioids, they know, can actually worsen pain and functioning, and probably has to do with adjusting the threshold for pain. The risks are dose dependent. The higher the dose, the more likely you are to have one of your patients die from an opioid-related death. This item here, the use of heroin and illicitly produced fentanyl has increased. And if we can believe Jeff Merkley, 70% of the people who have illegal drugs or street drugs have gotten their start from using prescription drugs that were probably prescribed with best of intentions for a condition of relieving pain. Not surprisingly, the CDC says non-pharmacologic approaches are recommended for analgesia. And if not non-pharmacologic, at least non-opioid medicines would be a good place to start. So these all seem like reasonable things to talk about. And the backdrop for all of this discussion is that we now recognize opioids have been aggressively and misleadingly marketed to physicians, and drug companies who did that have paid fines. Federal bodies and state medical boards receive funds to promote pain relief. And if you've been in practice for a few years, you maybe do remember that this is the case in Oregon as well. The Board of Medical Examiners adopted as part of their educational curriculum lectures that had to do with pain as a vital sign, the importance of relieving pain, the consumer's right to have adequate pain relief, the consumer's ability to judge the severity of their pain, and the doctor's obligation to do something about it. So some of the money came through unrestricted grants that traced back in my reference. Who is responsible for the pain pill epidemic is from the New Yorker, but traces that source of funding back to Purdue Pharmaceuticals, for example, one company that produces OxyContin. I did say I have no disclosures, right? I have no good ties to any of these sources of funding. Experts with pharma connections have rallied to criticize CDC proposals. So even though the CDC came out with reasonable evidence-based proposals, they were attacked by groups such as the Interagency Pain Research Coordinating Committee, which is a federal body that should be composed of people who have no stake in this, and yet some of those individuals had undisclosed ties to drug companies. So they were receiving sources of income from drug companies, and they attacked they had various criticisms to make about the CDC recommendations. So I'm building this argument to say, this may explain why the climate is a little bit different in the United States. Now, people are hearing about these things. Now, back to the point, if there's any question in your mind, has the use of more and more drugs proliferated in the United States, let's just say, increased risks? This is from Henry Kaiser Family Foundation. 4 billion prescriptions per year, increased drug costs estimated at $259 billion per year. I think that comes from the year 2014. Let's look at this slide, which is a little bit busy. I'm going to step over here and just say, my concern has more to do with age greater than 65. So that's this column here. In this particular study, which is taken from the National Health and Nutritional Epidemiologic Survey, it's a big survey, thousands of individuals. They're representative of the population in the United States. We see that at this age of greater than or equal to 65, more than something like 90% of people are taking a drug in the preceding 30 days, and the number who are taking more than 5 is around 40%. Now, it's not increased a lot over that time, but it's high to begin with, and you can see that it's gradually increasing over that period. Another study was done, if we needed another one to show us. This one happened to be another nationally representative sample, the National Social Life, Health, and Aging Project. And so they looked at a time period from years 2005 to 2011. They looked at individuals who had a minimum age of 62. So again, elderly individuals. The mean age was 71. So they looked at one point in time, they looked at another point in time, not necessarily the same individuals, but their sample. They did in-home interviews, also inspected directly what was in the pill bottles at, in the cupboard or the kitchen or the bedside to confirm that. So the use of any medicine went during that time period from 84% to 87.7%. More than 5 drugs, similar to the data I cited on the previous slide. They also looked at dietary supplements, and you can see how frequently dietary supplements are part of the picture. And then they used micromedics to ask the question, how many of these patients are susceptible to a drug-drug interaction just based on the drugs that have been prescribed and they're taking? And that theoretical level went from 8.4 to 15.1%. So that's not all adverse drug effects, that's just adverse effects from drug-drug interactions. Well, another sidebar, but I wanted to make this topic somewhat current. So from the Oregonian last September 4th, pretty recent, we see a picture of Heather Bresch. She's now the chief executive of Mylan Pharmaceuticals, and they're the ones who produce the EpiPen, which has an auto-injector. They are a generic drug company, but what happened was kind of interesting. They have now got a drug that's cheap, that's epinephrine. It costs no more than $10 a dose, very likely. But the dose is now in the auto-injector. The auto-injector is under patent, so they have been able to increase the price by 400%. You buy 2 of these at a time, they cost $600. Schools are obligated to have these available now through legislation that was kind of worked its way through Congress under the influence of Mylan Pharmaceuticals, and the medicine has to be thrown out every year. So this has become a $1 billion drug. And one of the arguments that's made by the executives at Mylan is that a drug ought to be priced according to its value in the marketplace. So if this is a drug that saves lives, should it be cheap or should it be expensive? And they are also saying our motivation is very linked to share owners, because share owners care about the stock price. The stock price goes up, that's good for share owners, it's good for us too. So we're aligned. The other argument they make is that really people don't suffer here because the payers for these medicines are employers or third parties, insurance companies, wealthy individuals, wealthy entities. So I think the New Yorker anticipated how this was going to go when they said in this cartoon, Robin Hood says, what about selling drugs to the rich and keeping the money for ourselves? Which is interesting. But many of the people who buy drugs also have copays, and sometimes these copays are crowding out other sources and other kind of costs that are important, like housing and nutrition. So finally, we work our way through this set of ideas, and we get to a point here where maybe you recognize yourself, maybe you recognize it among others, patients, your children. There's a certain amount of disillusionment now. There's a certain amount of suspicion. There's even backlash developing about doctors who prescribe too many medicines. For example, if you Google zombie and antipsychotics, you'll find there are court cases now. That's the first thing that comes up on Google for zombies and antipsychotic court cases that in which individuals are alleging that doctors did what we might call promiscuous prescribing for patients in nursing homes who had those behaviors that are difficult to manage in dementia. Anyway, I don't have to go further than my daughter, who said, wait, her obstetrician said, you can take Benadryl. And she looked up Benadryl, and she said, why would they recommend Benadryl for me? I now know what the FDA says about it. So this, now you see I'm at part 2 of my talk, and it's 8:32. So I'll keep moving along. And I'm not going to belabor this because I think everyone knows it. I'm just reminding you of what you know. And that is that changes in metabolism, pharmacokinetics, pharmacodynamics characterize elderly individuals. And so in many cases they require additional thinking before you prescribe a medicine, or at least you may want to adjust the dose of the medicine. These are individuals, the elderly. They're different from you and me, or at least different from you. They may have more conditions, and if they have more conditions, they tend to have more drugs prescribed under drug guidelines. They may have additional consultants prescribing their medicines, and the consultants don't always confer on what's the best combination of medicines for their conditions. So they are likely to have more drugs prescribed. Inevitably, they have more side effects. And if they're subject to reflex prescribing, their doctors may be some of those who are prescribing another drug for the side effect that's created by the first drug. Has anyone heard of OIC? OIC, anyone? You're not watching the news programs at night then, because the advertisements that accompany the nightly news are OIC. This isn't a pop quiz, so there's no entitlement here. OIC is opioid-induced constipation. There's now new medicine being marketed to treat opioid-induced constipation. Watch the evening news, you'll see that it's being, the brand now is being promoted.
What is the drug being prescribed?
I'm not going to go into that. Sorry, but I'm not allowed to talk about these drugs that are you know, except in the most generic way. Oh yeah, I can't. I'm just more commenting on the phenomenon that it begins with L. Okay. I'm just commenting on the phenomenon of using one drug for calling it a condition. Opioid-induced constipation is now a condition, trying to give it some formal standing so that another drug can be prescribed along with the opioid, and that's interesting. And it's not one of the older, you know, generic drugs. So for older individuals, they have a different life expectancy that just sort of like must translate into a different idea about drugs that may take years to exert their effect. Or it may mean that avoiding microvascular disease in a diabetic is not going to call for the same kind of tight control because they don't have the years ahead of them to be able to reap the benefits. I say there's an expensive polypharmacy, and that I kind of making the argument that expense is also a risk. It's a risk to the individual. It's a risk to our society if we're spending money on drug treatment that is better spent on some other aspect of maintaining health. And finally, and if you remember my case number 4, having to take 12, 13, 15, 18 drugs a day is a kind of a form of, it's a pill burden. It's a form of misery for many older individuals who may have xerostomia, who may have presbyosophagus, have more difficulty getting those medicines down. Turns into kind of a contested issue among family members who want to try to give them the medicines. So pop quiz, let me ask this question the right way. If polypharmacy is the problem, what might be the solution? Where did I hear? I heard it. Where did I hear that? We have a winner. Good. Pop quiz number 2. Can you? Yes, he said deprescribing. And I don't know if you were looking at this slide, you know. Oh, sorry. Okay, deprescribing, so that's kind of the point. It's a new verb. You won't find, if you Google deprescribing, you'll find very little on deprescribing if you go back 5 or 6 years. You'll find it's increasingly a verb that is in the medical literature. Interestingly, it's increasingly a verb that's being used in articles that come from countries other than the United States. And one of the places where it's been talked about is in Australia. The concept is not complicated. Deprescribing is the process of tapering or stopping drugs aimed at minimizing polypharmacy and improving patient outcomes. Who could argue with that? So again, back to the point, you don't deprescribe if you don't prescribe, so you've already eliminated the need if you're thinking about an alternative to a medicine in the first place. I also want to say, are there pharmacists in the room? Please raise hands. 1, 2, 3, 4, 5, 6. Okay. I mean, I really want to credit pharmacists, not only for coming to this talk this morning, thank you, but in general, I want to credit pharmacists for sort of leading the national dialogue about deprescribing, because when you go to national meetings, it's often the pharmacists who are trained to dispense medicines who are at the podium saying, here's how we can cut down on side effects from medicines. I consider this. And I would like to just encourage pharmacists to have that kind of dialogue with the prescribers in the moment when medicines are being prescribed. So assertiveness training for pharmacists might be one of the things I'm going to promote today. But I do want to credit them for playing a leading role. And I want to say, just to remind the people who write prescriptions in the room, who are the people who write prescriptions? And oh my gosh, well, many of you do. So I do want to encourage you to use the expertise that pharmacists have. They train in this field, and they are very good resources and should be included in the considerations of prescribing medicines. They and other physicians have also created deprescribing algorithms, so I'm promising to get to that topic as we move along. We might ask, well, wait a minute, if it's so simple to deprescribe, why don't we do it? And that question was put to primary care providers in the VA system. I think it's probably very similar for others who are in different systems. And one of the reasons for not prescribing is simply lack of knowledge. And 39% in this survey were not aware that there were increased risks and diminished benefits for tight glucose control, or for a low hemoglobin A1C for older individuals. Well, I can't blame them. I mean, that's only recently been adopted as a standard by the American Geriatric Society, by the American Diabetes Association, to loosen up on control of the hemoglobin A1C. Liz, yeah, would you agree, in older individuals, because they don't have the time to benefit from the microvascular effects. So there's also on the list fear of bad report card, and I think that refers not only to HEDIS measures that have to do with continuation of medicine for hypercholesterolemia. I think it refers to some of those people are subject to Press-Ganey kinds of patient satisfaction measures. So there's some hesitation about doing something that patients might question, about not prescribing the medicines that patients feel will be best for their condition. Fear of legal liability, I think that just comes along with doing something and thinking there may be a bad outcome, and whether it's causally related. It may seem like that if I stop a medicine that some doctor has prescribed in their wisdom, and then there's an adverse event of any type. And then I think importantly, not enough time to discuss. And I think not only are drugs prescribed sometimes because there's not enough time to discuss what the alternatives are, or why the drug might not be the best thing, but also it takes time to explain why you would be stopping a drug. That it sounds like second guessing either your own previous decision, and it takes time. So this is part 4. What's happening in the world around us? I think I missed a pop quiz along the way. What's the other developed country that allows direct-to-consumer advertising? Who said it? Somebody got it. Who? I heard New Zealand there. Who? Judy. We had a winner here. You already awarded? Was it a tie? Come on.
I didn't give the answer, but yeah.
Did you give the answer? It's a tie. 2-way, Jude. Would you please? New Zealand. In the United States, it's a First Amendment right to advertise drugs to consumers. I believe you, sir. Just what I'm encouraging you to do. This is my counter. I'm encouraging you to buy a latte for a pharmacist and sit down and have a talk about deprescribing with these coupons that we're handing out. So in any case, direct-to-consumer advertising can occur in the United States with caveats. In the tiny print, you have to have, or in the sort of voiceover, you have to say, what are the side effects of this medicine? And other countries don't do that. And New Zealand is thinking about repealing that, and there's some discussion about that in the United States as well. Even at the American Medical Association, there's consideration that maybe we should withdraw that First Amendment right. So beer's list, it's not about Pyramid Ale and Deschutes Lager and so on. That's marked beers. We'll talk just about that for a minute. Choosing Wisely campaign was sponsored by the American Board of Internal Medicine, Chris Castle, and it was in parallel, the Consumer Reports has put out literature for patients and handouts such as this Choosing Wisely materials, and they're available on a number of subjects for patient education. So patients who are reading Consumer Reports will come into your office and say, you did just the right thing. I read about it in Consumer Reports. Thank you so much. There's more published medical literature, as I mentioned. Google Deprescribing, you'll find much more there. There are algorithms, and I'll get to that. There are Center for Medicaid, Medicare service incentives for looking at medicines that high-risk individuals are taking. There's a medication therapy management program that's mandatory for Senior Advantage and applies to certain individuals. And then I argue that there is a cultural shift among your patients and family members, and maybe right in this room, about over-prescribing medicines. So any hospitalists in the room? Okay, the hospitalists are busy in the hospital, I guess. There are 3 of them here anyway. This is specifically for hospitalists. Here's another current article which maybe reflects this climate change. This was a Kaiser Foundation News Service article that was picked up by Tribune News Service. You may have seen it in the Oregonian. The article concerns a function at the Santa Monica Hospital for UCLA, where they do have a geropharmacist who spends his time in the hospital looking for opportunities to deprescribe. And he's quoted in the article about one patient saying, well, when I saw that she was on 36 medicines, I thought that was a matter of concern. Because for many patients who are in the hospital, well, let's say the literature shows that 20% of patients in the hospital are on medicines that may be inappropriate for them. So this is a big opportunity for hospitalists and pharmacists who work in the hospital. The Beers list. Okay, Mark Beers, unfortunately he died in 1991, but I'm sorry, he died subsequent to 1991. It was 1991 when he put out his first Beers list, and he was recognizing that older adults, somewhat analogous to pediatric patients, do require special consideration when you're thinking about drug doses and when you're thinking about what are the best medicines for their conditions. So he put out a list of medicines that were considered potentially inappropriate because they might be harmful in older adults. He did die subsequently. The American Geriatric Society accepted the charge, and in 2011 to update the list, and it was done again in year 2015. So a very updated list is now available, and the material was published in the Journal of the American Geriatric Society last November. There's not only an article with tables on drugs to avoid in the elderly, there are sections, companion articles that have to do with alternatives to drugs. They have to do with dosing and renal failure for selected drugs. They have to do with the major drug-drug interactions. So it's not encyclopedic, but it is an authoritative list that was arrived at through review of the previous list, through a Delphi process, collecting opinions from experts, collecting opinions from other leading societies who also contributed to the discussion and the review of thousands of articles in the literature. They also, by the way, were able to recant error to the extent they said, oh, we're not so concerned about nitrofurantoin now. It may be given to patients who have a GFR of greater than 30, whereas previously they said greater than 60. So I do recommend that for light reading and for a reference that you can use when you're prescribing drugs for the elderly. This is an article I thought was kind of intriguing because it was in the American Journal, the Journal of the American College of Cardiology last year. The authors were European cardiologists, and one of the authors had happened to have a coronary event some 25 years prior to the publication of the article. So he was put on the usual medicines, aspirin, beta blockers, statins, and ACE inhibitors, and he sequentially suffered side effects from those medicines after a period of more than 10 years. So he had GI bleeding, he had an episode of sinoatrial exit block on a beta blocker, he had an intractable cough with the ACE inhibitor he happened to be taking, and it made him stop and think critically about the literature, especially with these considerations in mind. Evidence from short-term studies can be projected over decades. Scant evidence on the outcomes of drug withdrawals, so we don't have much literature on stopping medicines to follow up those patients and see what happens to them. The trial results from the young old, as we discussed earlier, are often extrapolated to old individuals. Modern clinical practice differs from that when trials were conducted, in the case of coronary heart disease, specifically with respect to stenting. Projections of benefits assume hazards are constant over time when, in fact, they may cluster during the first 6 months or year after a diagnosis of coronary heart disease and not be the same after 20 years or 25. And then for elderly individuals, it may be more than what happens to them on a day-to-day basis in terms of side effects or loss of function than it is absolute longevity that governs what their preference might be for choosing a medicine. So the question is, how long, and this kind of refers back to the issue of what about those statins for individuals who are older than 79 years? You know, how long do you continue statins in more elderly individuals? Getting towards the time when I want to just open it up for questions, and I don't want to run over, but I will say, here's old-style pharmacy medicine reconciliation. These green balloons here. And in some instances, and in instances at Kaiser, we are thinking, oh, the pharmacist also has another set of tasks over here. These are the purple balloons that have to do with possibilities for deprescribing, and they include looking for appropriateness of the drug related to the conditions and the state of the patient, drug-drug interactions, drugs to avoid in the elderly, the Beers list, adherence and how to improve that, duplication, and the side effects that may be present but may not even be reported, particularly in elderly individuals who may have intellectual impairment. So finally, I'm kind of maybe going to wrap it up by talking about this algorithm. A couple of researchers in Israel, and one was named Garfunkel, and he's the lead author of this study that was reported in 2010 and has only been talked about very much, it seems, in the last couple of years. He and his geriatric partners worked in a Hebrew rehabilitation center, and they conceived the idea that maybe these patients don't need all the medicines they're taking, and so they, in a kind of a pilot study, they said, let's withdraw the medicines. They did that in a systematic way. They followed the patients. They did it with consent of the primary doctors and either the patient or their proxy. And they were encouraged by the results of that study. So they said, let's also do this in our consultation practice in the outpatient area. So they looked at 70 patients. They stopped 311 medicines of all types. And the results were that they had to restart the medicines in 2% of instances because of the original indication. But they had what they called success, and that is the patient and the doctor consented to stop the medicine and did not have to restart them in 81%. And instead of suffering ill consequences, their study showed global improvement of health in most of those patients and an actual mortality benefit over a study period of about 19 months. So there was a 14% mortality benefit in the patients who had drugs pared away. This is their algorithm, and this is the reference to their algorithm. And you know, I don't know if you love algorithms or if it looks a little bit complicated, but really it is a matter of saying, is this the best drug, and are the benefits outweighing the risks, including all known side effects? And really you can go straight to continue with the same dosing rate. But as was demonstrated in their study, when they go down the other pathway and ask, is this the most benefit for this particular patient with this patient's conditions, and is the patient having any adverse effects from the drug? Is there another drug that might be superior to the one in question? And finally, can the dosing be reduced? They ask that series of questions, and they proceed to either continue with the same dose or reduce the dose or shift to another drug or just stop the drug entirely. And as you saw from the previous slide, there were many cases where they were able to do that and show that it was safe to do that through their careful follow-up. So if you want to think about a simpler algorithm, I would think of 3 S's, either stop or shift or simplify. Stop drugs that are unnecessary. I'm quoting a statistic from Age and Aging. You know, a high percentage of individuals who are discharged from the hospital are shown in retrospective surveys to be on a drug that's either unnecessary or contraindicated on the Beers list. I don't think that should surprise anyone. Stop duplicates, shift to a drug that's safer, less costly, maybe, and I say shift to non-drug treatment. I don't say stop the drug because the treatment continues. It's just a non-drug treatment. Or simplify the dosing schedule, substitute one drug for 2. The New Yorker again, I think they captured it. This is the simplified regimen, perfect for geriatric dosing. Sunday, Monday, Tuesday, Wednesday, Thursday, Friday, Saturday, a single dose a day. And studies show that if you get to QID dosing, you have only 50% adherence. Liz, I'm either going to run over or I'm going to stop. Because if we want to have any time for questions, it's now about 8 minutes till the hour. Yeah. Oh, I gave people a chance to get up and leave. I'm going to go to my benefit slide and not belabor. There are some things that if you have questions about what's happening inside the Kaiser Permanente, these are some of the things. Think of column A. Instead of going to column B, think of going to column C, which is think about non-drug alternatives for treatment. This was a medication therapy management study that was done at Kaiser with a matched cohort, and when they simply looked at patients with complicated medical regimens and stopped unnecessary medicines, in the course of a year they reported less hospitalization by a small margin. But more importantly, they had a mortality benefit of 14%, so that was similar to the study by Garfinkel. This is the slide with which I'll conclude, and that is to say, without, I hope, fear of contradiction, but I invite discussion, deprescribing will simplify care, reduce adverse drug effects. We've shown that it will reduce hospitalization by a small but significant margin. It will, and I argue, will improve adherence because it's just easier to keep track of 4 drugs than it is of 36. It reduces costs, both the costs associated with drug delivery or drug administration and the cost of the drugs themselves, and saves lives, at least in the 2 studies where it's been put to the test, 14% mortality benefit, which is not bad. So at this point I say thank you for coming, and thank you for paying close attention and participating. Question?
Could you please comment on insomnia in elderly and especially about melatonin?
Would I please comment about insomnia in the elderly and especially about the issue of melatonin? So one of the things that's nice is to have readily available patient handout materials, and insomnia in the elderly is prevalent, of course. The Beers list from the American Geriatric Society points out to the non-diazepine, diazepine receptor drugs, the Z drugs for sleep, and makes the case, I think, that those medicines can confer more harm than benefit and ought to be avoided. They're certainly not meant for long-term use. Even in the short run, they may not be as effective as would be hoped, and they certainly do have potential side effects. Melatonin, in my mind, is a simpler drug with few side effects. Is it effective? I guess you only know by trying it and seeing if it does seem to work, but I think the side effects of melatonin are pretty limited. Anyone else have experience with melatonin they'd like to share? Yes?
I found a melatonin chamomile preparation.
Oh,
It's called Midnight. And it, for me and some of my patients, significantly better than melatonin alone.
I was going to give you the microphone, but melatonin chamomile, and is that a commercial product? Melatonin
It's
chamomile.
called Midnight.
Midnight, over the counter. So you've had good success with that. Okay. Oh, melatonin chamomile. Chamomile tea, you know, the element that goes in tea. That's available over the counter, and it's named Midnight.
The melatonin is available itself.
Yes, it is. I know it's an herbal supplement, or it's not an herbal supplement, but it's sold over the counter. Yeah. But for patients who are pretty wedded to their Z drugs, having a little backup from literature such as Consumer Reports, these handouts are available, and they match what the American Geriatric Society is promoting as well. Yes.
Back up a couple of slides.
I can.
I think column B is
Oh, sure. Yeah. So thank you for that comment, because we have, on this list, we have insomnia. And we think not a Z drug, but we think sleep hygiene. And I don't know if everyone is aware or familiar with what sleep hygiene is. That's And that's also treated, sleep disorders are treatable by cognitive behavioral therapy too, if that's available to you, if they're experts in cognitive behavioral therapy. What does sleep hygiene mean? That means not going to bed when you're not sleepy. That means not sleeping during the day. That means if you do wake up at night, don't curse the darkness, but do something that distracts you, until you feel sleepy, and then go back to bed. Don't use your bed for activities that don't involve sleep. So that's kind of like conditioning, so that when you're in bed horizontal, sleep is what you're doing rather than reading or eating or something else. I would also say sleep hygiene may mean getting out so you get the natural stimulus to melatonin. That is, you get sunlight, and I'd add exercise to that list. So this is just me making it up a little bit about sleep hygiene, but that's sleep hygiene. Now, cognitive behavioral therapy is something else, again, which means to a certain extent it's a matter of reframing, and that might come into play if you're so distressed by your lack of sleep that you're not sleeping because you're so distressed. You reframe, you think, how lucky I am, I have some undisturbed time. Here at 2 a.m., I wanted to catch up on listening to music, reading, that sound convincing? Cognitive behavioral therapists would put it in I think, a more sort of structured, systematic way. It's 1 minute till 9. I think so. Okay, thank you.
Are you aware of any data regarding falls related to
Okay, you bet.
insomnia drugs?
Oh, yeah, that's definitely.